Top Med Talk.
This piece is taken from the 8th Australian and New Zealand Symposium of Perioperative Medicine Special Interest Group. Updates in Perioperative Medicine 360, which took place between November the 7th and the 9th of 2019. Hope you enjoy this talk, and if you do, don't forget to check out topmedtalk.com and make sure you subscribe to us on social media as well. More details about that to follow. Before that, let's enjoy this talk.
Our next talk is by Professor Clifford, who is the Director of the Division of Research and Optimal Patient Care at the American College of Surgeons, where he oversees all the quality improvement programs. He's also the Director of the American College of Surgeons' National Surgical Audit Improvement Project, that I'm sure most of us know about. Clinically, Professor Cole is a double board certified surgeon with a practice currently focusing on patients with colorectal cancer. The title of his talk is Improving the Quality of the Patient Surgical Journey.
Great, thank you. Terrific. What I'd like to talk to you about is some of the things that we're doing in the U.S. To help our patients do better. I'm a surgeon at UCLA in Los Angeles, but the other hat that I wear is I direct all the quality programs at the American College of Surgeons. And so we have a lot of quality programs, and I'll show you what these are, but what I really want to do is to kind of highlight some of the programs that are new and that we feel are really important for helping the operative team of people, the surgeons, anesthesia, the geriatricians, the nurses, the pharmacists, take care of the patients better. And what we're finding, and I think that it's a crux of this meeting, is that what we do before we get to the operating room is sorely lacking in the States, and we are putting in place a lot of programs to help support what happens before the patient goes to the operating room, even deciding if the patient should go to the operating room. And then we put these structures in place at the hospital level, which I'll share with you. So let me get going and start talking about this. These are the programs, and this is a timeline. The American College of Surgeons has 80,000 members. They're mostly surgeons. And it started 100 years ago with these men. And really the saying is that trying to do what's right for the patient. And so the College of Surgeons and the division that I work in is really developing these programs. We had a cancer program that started in 1922 with a cancer registry, the trauma program, if you come to the States, where there's level 1, 2, 3 trauma centers. That is the College of Surgeons that go in and verify that in each of the hospitals that it's a trauma center. We have a number of database programs, the ACS NISQIP and then the PEDS NISQIP and so forth, and then some programs that we've developed more recently. But really the key thing is that we have quality programs in 3,000 hospitals in the States, and mostly the larger hospitals, so it's really a large percent of the operative patients is in a hospital that we visit every 3 years. A lot of times we have registries in these hospitals and we collect data and we feed it back in this way. We call this a caterpillar plot. And each of those yellow dots is a point estimate. The up and down line is basically a confidence interval. And so the break point is the pink line. So these hospitals here are doing worse than expected. We do a lot of statistical analyses, which I won't get into, but these are the hospitals that are statistically doing worse than expected. We collect, if you're in a NISQIP hospital or if you're in any type of hospital that collects risk-adjusted data, there's a lot of predictors, and so we can predict how patients do based on the millions and millions of cases we get in, and we can tell how a hospital is doing. And so these hospitals on this end are doing worse than expected, and these hospitals are doing better than expected. What we've done after decades of having a whole bunch of data in hospitals that we visit, we've started to go into hospitals to see what are these good hospitals doing across the board for any type of patient, whether it's a trauma patient, a elderly patient, a pediatric patient, a colon patient, a hip patient, all of these things. What are hospitals doing? And we started to kind of collate these things in a very qualitative way. And these are some of the things that we saw. Evidence-based standardized process, so standardization, we all know that, and anesthesia has led the way a lot of times in healthcare. Case review structure, that can a place find its problems and then fix them. A lot of times surgeons will like, I don't have a database, but I can't remember the last time we had a problem. We must be great. They don't find their problems, so there's nothing to fix. But that's probably not true. We always say that a surgeon who doesn't have any complications either doesn't operate or is a liar. Data with feedback and actionable data. So how many times does a hospital, and these better hospitals, have data to see how they're doing and so forth. We spent the last 4 or 5 years writing this book called The Optimal Resources for Surgical Quality and Safety, because that's a mouthful. We just call this the Red Book. But basically, this is all the lessons that we've learned from these thousands of hospitals from amongst all these programs to kind of get at what are the foundational things, the infrastructure, the resources, the organizational structure, management that these hospitals have in place to really help support giving high quality, safe, reliable, standardized, high value, whatever the word is you want to use, care. And a hospital, and in the States, and I'm sure it's the same here, same everywhere, where you have all these metrics that you're trying to chase. We have 1 year we have to deal with SSI, another year CAUTIs, and catheter-assisted associated urinary tract infections. We have to do readmissions, we have to do mortalities, and we're kind of running all over the place. And unless we have a set structure in place, a set organization, resources in place to kind of do this, we're just chasing our tails, and it is not sustainable the way this is. And hospitals and the burnout that we see in the States, the problems of all that, the frustration is because that setup, that foundation is not there. And so we wrote this book, and we're starting to visit now hospitals. And I was just in Sydney visiting Westmead and doing a Red Book verification visit. We have a number of standards, and we go into hospitals to see that largely these bullet points on the left side, that does a place have this in place so that whether it's general surgery, colorectal surgery, trauma, ortho, urology, ENT, are they doing all these things across the board? And so this book really has also started to kind of get at this issue of the 5 phases of care. So to a lot of surgeons, and we just had our surgical clinical congress last week in San Francisco, and everyone perseverates. All the surgeons go to all of the sessions about what to do in the operating room. How do you throw this stitch? How do you put in this port? How do you and nothing about the other phases. And so we're trying to talk about having 5 phases of care, and really that the continuum of what a patient undergoes is really important and lends to the quality. So when we talk about the 5 phases of care, we've kind of named it these things. And it's not new and it's not original, but we just kind of put it into the book, and now we just kind of always say 5 phases of care. The preoperative phase, where decisions are made to operate or not, where comorbidity assessed, where kind of all of this, we're talking to the patient whether just to have an operation or not. If it goes forward, the immediate preoperative period, about the 24, 36 hours before the operation, where if tests were ordered, if things were done, that's kind of the stopgap to make sure all those things were done. Make sure that the patient is really ready for the operating room. A lot of times it happens that morning of the operation, where the nurses have their checklist and anesthesia has their checklist and the surgeons have their checklist to make sure that everything is set to go forward with the operation. Intra-op, all the stuff that we know about happens in the operating room. Post-op, and then a big thing is post-discharge. Right now in the U.S., when we have bundled care, where we get one price from our payers to go from 1 month before to 90 days after the operation, the biggest cost right now, the biggest driver of cost is post-acute care. After they get discharged, if they have to go to a skilled nursing facility, to rehab or whatever, that is the biggest driver, the biggest delta of value of costs in the U.S. And so that's a big piece that a lot of surgeons, the patient's discharged, they kind of don't think about it, but that's a huge piece. And a lot of times we know that what we do before the operation will dictate and kind of can predict how the patient's going to do post-discharge. So what I'm going to do is to talk about 5 things here, these programs, and I'll do it very quickly, but you can get my slides are available. You can have them. But if you go onto the facs.org website, all of this information is here. I'm going to talk about Strong for Surgery, our new geriatric surgery verification program, a calculator that we've revised, the Improving Surgical Care and Recovery program, which is basically enhanced recovery, and then the NISQIP program and how we're putting some patient-reported outcomes into that. So a lot of times the surgeons think about in the States, think about just the operating room, but really what we need to focus on is before getting to the operating room. And it's the doctor's office, whether it's the surgeon's office or the anesthesiologist's office, the geriatrician's office, whatever. It's a lot of the decisions that are made before getting to the operating room. We have this program called Strong for Surgery, and it's a program for readiness and optimization. And we have to explain to the surgeons that readiness is getting the patient ready so that they're not canceled for the operating room. But that's not good enough. We want to optimize, and we're using the word optimizing the patient, that the patient will do well after they get discharged from the hospital, whatever it is, whatever, ortho, colorectal, whatever. Are they optimized that they're going to do well and sail after they leave the hospital? We've done many studies at the college, and there's a lot of studies where you go see the patient the day after they get discharged at their home, and the rate of the doctors saying that come back to the hospital is very high because nobody really sees the patient after they get home, or not enough do. And when we discharge them, they are not fully optimized for that. And so the aim of this Strong for Surgery program is to really help hospitals and clinics optimize their patient in the preoperative phase, all of these things. So let me move forward. So we've developed some checklists, and they're very simple checklists. The surgeon who really led this is a thoracic surgeon and had a lot of deconditioned patients with esophageal cancer and lung cancer and whatnot. But he kind of put these together, and then we got a whole bunch of other surgeons to come in, and anesthesia and the whole perioperative team to put these into play. These checklists there's 8 checklists, and these are supposed to be just a guide. And really that the hospitals that are doing this kind of put it into, there's a few hundred hospitals that are doing this. They kind of use it as a guide to put it into their system so that there's standardization in the preoperative setting. These are available on the website. I know they're too small to read, but basically the first 4 that were done were nutrition, blood sugar, smoking, and medications to make sure that they're on board. The things that people asked for are pain control, prehab and frailty, patient directives, and delirium screening. So these are the first 8 that we've done. We're probably going to put more in, but there's going to be some additional things. But these are just a guide to what's put into play. Again, the idea of readiness versus optimization is a key point, and we can't tell this enough to the folks in the States. I talked about doing these optimal resource or this Red Book visits where there are 14 standards, and again, those were the bullets on that left side. And one of the standards is the 5 phases of care and how much standardized care is happening in a hospital. And this is the standard. It's 2.1 standardized process in the 5 phases of care. And in the pre-op setting, and we check at a hospital and we ask all the surgeons and we see what's going on. And we'll ask the orthopods and we'll ask the urologists and we'll ask how do you pre-op your patients? How do you bring them to the operating room? And a lot of times it's like, I think they're ready. I ask them if they can do well, and then I bring them to the operating room. And for most part, for our pilots up to this point, I think we've done 13, 14, 15 hospitals. The vast majority of them do not have a standardized preoperative program, which is a shame, and there's a lot of variability in the hospitals. When we rate these hospitals on a scale of 1 to 5, and you can see for the standardization, it's a 3.5. Most hospitals have very good standardized care in the immediate preoperative phase where there's all the checklists and they do it the same way every time. And a lot of times in the U.S. at least, the nurses are amazing at that. They will not let the patient go until that checklist is already checked. In the operating room, you probably have here the timeouts and the briefings and then making sure that all that is standardized. The most surgeons have things standardized, most anesthesiologists in the operating room. And postoperatively, the enhanced recovery protocols have been standardized and is really taken off, at least in the States. And so those 3 phases, immediate pre-op, intra-op, and post-op, are pretty well standardized. Where things are not standardized and might be difficult is post-discharge, but the greatest opportunity is in the preoperative phase, and that's where most of these hospitals are falling down with that. So standardization was least developed in the preoperative phases as we're visiting hospitals and doing that. So that's a great opportunity. And important. So, and I'll show this picture to our residents, to our trainees. And half of them get this wrong. In order to improve patient care, be more reliable and efficient, we should obviously standardize. And so if you have, and I always give them the example of 3 surgeons, if you have 3 colon surgeons at UCLA, they think standardization is this, that I do things the same way every time, and Joe does things the same way every time, and Jane does the same things every time. But really what we try to do is this. And truth be told, it took us 3 years to standardize one protocol amongst the 3 surgeons, and 2 of us trained at the same place. But it is possible, and this works, as we all know, much better. I'm going to move on to the second thing, which is the geriatric surgery verification. We know in the U.S. and around the world, for most places, that there's an increasing number of older adults undergoing surgery, and it's disproportionate, and the outcomes are, whenever we measure them, and even if it's risk adjusted or stratified, it's worse. So mortality is higher. If we mention length of stay or readmission or anything that we measure is usually worse there, and there's an opportunity to get better. So what can we do? We started several years ago kind of writing guidelines. Like, if you don't know what to do, I'll write a guideline. But the data are not great here, but, we still wrote guidelines of what to do pre-op, what to do post-op, and then delirium is a huge thing because we either over-medicate them, we under-medicate them, we just kind of just whatever. And so it's a good start, but when we wanted to be much more sure that care is going to be better for the older adults, rather than putting a guideline into play and having nobody use it, or we write a good paper and it takes 19 years until somebody reads it. What we did was we started to have an idea of, like, can we put a geriatric surgery program into a hospital that has standards that they have to meet, and it goes across all phases. It ensures multidisciplinary care and whatnot. So we got a whole bunch of stakeholder organizations. We had a grant to work on this for the last 3 or 4 years. We had our payers. The biggest payer in the United States is the government, Medicare, and so we had them at the table. We had patients and families. We had advocacy regulatory groups, healthcare professionals, geriatricians, gerontologists, surgeons, anesthesia, hospitalists, ED folks, and whatnot came up with this. And so you'll notice that we don't tell people how to do care. We don't tell them that they should do X, Y, or Z. We say, what are the resources to start with that you need to take care of an older adult undergoing surgery? And so we call all these manuals optimal resources in a hospital. And if a hospital is not resourced to take care of an elderly person undergoing a major surgery, then maybe they shouldn't. And if, just like a trauma place, if they're not resourced to take care of a trauma patient, then they're not going to be a level 1 trauma center. And so we have taken this strategy, and it seems to work across these hospitals, that you get the resources first, and then you get the organization and the processes and the care that follows, and then the outcomes. So I'm not going to go into all the 30 standards, but highlight just some of them that happen in the preoperative time period. The number one thing that all of these stakeholders told us that we do not do well in the States is align the care with the goals of the patient. As we know that in the elderly patient, they might have different goals than in the non-elderly. A 88-year-old might be different than a 38-year-old in terms of what they would want for an operation. And too often we're just like, oh, you have cancer, we're going to take out your colon. You have this, we're going to do this. And whereas, they might have something different. And so we're reteaching people how to talk to this population of saying, what are your overall health goals? What are your goals for this treatment? And it might not be to have a shiny new hip and no infection. It might be just to be able to take a walk to the store to buy a pack of gum or to dance at, their granddaughter's wedding or whatever it is. But these things are usually not addressed well enough, And so this is a huge standard and maybe the most important standard that we have in this program. You can imagine that the preoperative workup of vulnerability, which is the frailty stuff, but what we're finding is that people are sometimes asking these, but then not doing anything about it. Or doing something based on my knowledge, on the surgeon's knowledge, which is basically not enough. So not getting the geriatrician involved, or not getting the hospitals involved, or not getting anesthesia involved. And so how do you have you do a vulnerability screen and then a management plan and interdisciplinary, and also talking to the primary, the PCP stands for the primary care provider, and so making sure that that person knows what is happening in the hospital, and also getting information from the primary care provider that you might not know just by talking to the patient. So I'm not going to go into details of this, but this is the overall health goals. So this is the vulnerability screen. A lot of people have already know what the Edmonton frailty scale is, and this is the one that all the hospitals and all these stakeholders decided to use. So people can use whatever they want to evaluate frailty and vulnerability of the elderly, but this is the one that I think most hospitals are putting into place. If you want to get information on more on this, it's facs.org, geriatrics. The 30 standards were released just this past July. Hospitals are signing up to be participating in this program. Part and parcel with the older adult, some of you might have known or seen or used the ACS NSQIP risk calculator. NSQIP is a 30-day outcome risk-adjusted database that uses clinical data, not claims or billing or coded data. And it's been a program at the college for the last 15 or so years. We've taken all that data and made predictive models so that if we put in there that this patient is, 87 and is going to have a colectomy and has diabetes and CHF and on steroids and whatever, we can push a button and predict what their SSI is and their UTI rate is and whatnot. And a lot of folks in the States at least use this as they're talking to a patient, like this is your risk of having this, this, and this if you're going to have a colon operation for whatever disease. And so this is the QR code that if you want to, I don't know if you can take a picture and use that, but or you just look on Google and facs.org or just look up risk calculator. But basically, this is the front page of it, and you just sign in, and then you put in your whatever operation they're going to have, and you just click off their age and demographics and what they have, and then you get, if the patient is over 65, and we had almost 200 different operations where we had enough data that we can make a pretty stable model to adjust, and there's some geriatric patient information of mobility aid and cognitive status and whatnot. Put all these things in, and then we can get some data. So these are the predicted risks of the complications, any complication, pneumonia, and all the so forth of the things that we have in the database. But we also added just a few months ago some of the geriatric outcome, the risk for post-op delirium, functional decline, use of a mobility aid, pressure ulcer progression. We just put this in there. It's free to use. This is something that we just thought was so important that we put it out there. And I know that as I visit a whole bunch of hospitals in all these different countries, that a lot of folks just use this as kind of sometimes as a guide, just as like, oh, I didn't realize that. I mean, this is a number that we have from it. And these are patients in the program. Most of it comes from the U.S., but this is at least a starting point to have a discussion. These are the cases, so and it's across the board of what hospitals put into this: orthopedics, general surgery, peripheral vascular, urology, neurosurgery, gynecology, thoracic, plastic, ENT, and cardiac. So it kind of goes across the board, and these are the cases, again, that we had enough data that we can make a stable prediction of what those things are. So I talked about strong for surgery, geriatric, and the calculator. I'd like to quickly go through the improving surgical care and recovery, which is basically an enhanced recovery. And then I'll talk about the calculator. Everyone, I think, probably knows about the enhanced recovery protocols, but I want to kind of share a couple things that we have learned. We had this big $15 million grant to help hospitals in the U.S. who've been living under a rock and didn't know about enhanced recovery protocols, to help them implement them, or the ones that tried to implement it and failed and couldn't do it. So this is a typical protocol. Colon seems to be the most common thing, colectomy in the U.S., and it's basically what's really great about these protocols is that there's preoperative, intraoperative, and postoperative things. So it goes across different phases. And what's also great about this protocol, when they work, or at least when they work better, is that you involve kind of the whole team. Preoperative nursing, anesthesia, surgery, pharmacy, advanced practitioners. We have a lot of nurse practitioners or physician assistants in the States. Postoperative nursing, social work, all of the team comes together. And it's better when they have data to know the compliance rates for each of these 12, 14, 10, whatever the hospital chooses, compliance rates. So at UCLA, when we first did this, I wrote an order. I typed in an order that the patient should get out of bed on day 1 through day 5, 3 times a day, and I thought that was happening. When we did an audit, it was 10% compliance with that thing. And so knowing that data is really important. As we all know from the literature, that length of stay, a lot of things get better. So length of stay in the States is very important because we are so focused on money, that having the patient leave sooner safely is good, without even trying, because a lot of people have infection bundles, but there's not really an infection piece in most ERAS protocols, and yet the infection rates largely go down. We get dinged when the patient comes back to the hospital, so we try not to have readmissions. The number one cause of a readmission in a surgical patient is a complication. If we are having less complications like SSI, and SSI is the number one complication across all surgeries, decreasing SSIs decreases the readmissions, and so a lot in the hospitals that the readmission rates are decreasing, again, by having standardized care, multidisciplinary standardized care. These are the two things that I think are important, that is a lesson for everybody to always learn about this. So people think that, all right, there's 12 things to do, 15 things to do, whatever. Can we just do a regression analysis and figure out that it's really only 1 or 2 things? Is it that, is it the amount of fluid that the patient gets in the operating room? Is it walking? Is it the multimodal pain control? And so we had a whole bunch of data, and we started looking at, if we look at any 5 processes or less, 6 to 9 processes, 10 to 13 of those things, and we looked at length of stay as the outcome metric, and it was really basically a dose response. The more the protocol you do, the more of the right things that happens for a patient, the better they will do. It makes sense. It's not the regression analysis, and you just got to do 1 out of the 14 things, and it's the key thing. It's a dose response. And so when people are putting that into play, the more you do, the better you get. Having data is really important, and I am not stressing it in this talk very much, but having data, knowing where you are is key. But what you do with the data and how you use it is as important once you have the data. So we looked at a whole bunch of hospitals and figured out and asked them what they're doing with their data. We audited them, and then we looked also at their results. And so there are hospitals that just collected the data. They thought they were good, but they never did anything with it. There are hospitals our hospitals like this. They collected data. They make these really nice graphs, and they put it up on the wall in the operating room and expect everyone to read it, which usually doesn't happen. Sometimes they take the data, they make those really nice reports. Instead of, in addition to putting it on the wall, they send it up to the C-suite of the hospital, so the CMO, the chief medical officer of the hospital knows it, and the quality people up there that, most surgeons don't know who those people are. They know what it is, but we don't. And then the feedback to the front line. So then the other hospitals give it back to me, give it back to the nursing team, give it back to the floor. And that's the only one that was associated with having better outcomes. And the data that's really important is both the outcomes, so the length of stay, the SSI, the readmission rates, but also the processes, that 10% got out of bed or 90% got out of bed on day 1 and so forth. Now, how often did this happen? Well, the data were collected, the process and outcome data were collected 64% of the hospitals, but how often was it given back to the frontline providers? 15% of the time. This has to get better. And so this is a key part about when we're trying to help coach hospitals to do better. Collect your data, make a report, give it back to the people who are taking care of the patients, and not necessarily just on the wall expect people to read it or up to the C-suite. The last thing I'm going to talk about is what I think is going to be a big thing, and you're probably doing it in this country. We're just starting to do this in the States, is really not just looking at clinical outcomes of having no mortality, no complications, but really looking at patient-reported outcomes. And having ideal improvement is having no morbidity and no mortality, but also better quality of life and patient-reported things, that the things that are important to the patient. And so in NSQIP, so NSQIP is a registry, again, that will measure the 30-day outcomes and make sure that a patient doesn't have an SSI or those types of things. But in line with the health and the health goals, we're starting to collect data. So you can get a copy of the slide so you can see these things. But we're going to use a generic a set of things of global health things, pain interference, fatigue, and physical function. But really, I think one of the more important things, especially in line with the older adult, the geriatric program, is the patient-provider interaction. How much effort was made to help you understand your health issues? How much effort was made to listen to the things that mattered most to you in your health issues? How much effort was made to include what matters most to you in choosing what to do? And when we piloted this, the scores were horrendously bad for a set of hospitals and the patients being treated in that hospital. And clearly, it's not an impossible thing to do for providers when they talk to their patients, but it's not something that is being done well enough right now. So we're trying to put this in not as a gotcha kind of thing and not as a penalty kind of thing, but just to let people know, let the providers know what's important to their patients, how they're being rated, and it's only as a quality improvement and not as a regulatory thing. And the other scale is something similar to that, and this is being performed in that. So there are 3 opportunities to improve the quality of the patient journey. I think a big area is the preoperative appropriateness, whether to have an operation or not, and how is that decided. The readiness and optimization. Number 2 is standardization. There's so much more that could be standardized than is standardized. And the post-acute care and results and including the patient-reported outcomes into that. I want to show there's a couple slides left, and this is a very important thing for regardless of what payment system people are in. Starting soon in the U.S. and starting now as pilot projects from Medicare and a whole bunch of our private payers, we have this thing called bundled payments. And we get for every, and I think these are hip replacements. So this one hospital, each one of those lines is a patient. And so I think they did 350 hips that year. And for each one of the hips, that hospital gets almost $20,000. And they will, and it's figured out in a way, but they'll get $20,000. If you look at how much each of those hips cost, and that green line is the $20,000, these patients exceed that price. And so to a hospital, and that might be a sick patient coming in, these are all elective hips. And basically what the hospital wants to look at and see is that can they get the green space where they're going to have profit on those profits. It's a terrible thing to use when you're talking about patients. You want the green to be bigger than the red. You want to minimize the red. And what are the things that are in the red, and what are the things that hospitals are doing to do that? Well, what we're finding is that hospitals are preoperative optimization, making sure, especially in the post-acute care phase, that things are doing better. Using the risk calculator to stratify the care, but also to appropriately care for the patient. If the patient is at high risk and they need to have an ICU bed and the cardiologist needs to see the patient beforehand and all of that stuff, the preoperative risk, knowing that beforehand rather than afterwards and the patient's having evolving MI and then you call cardiology, that's often too late. Standardized protocols, whether it's an enhanced recovery protocol or whatever we want to call it, and optimized care through looking at through the 5 phases. And so that's what we're seeing hospitals right now doing to really get the green to be bigger than the red and improving the care. And it's unfortunately taking a bundled payment system, making places do that, but doing it probably before that gets into play is what we would want to do anyway. So I'm going to end here. Can we improve quality? It is absolutely possible, and I thank you very much and appreciate your attention.
Top Med Talk. Thanks for downloading Top Med Talk. Let me just mention to you, Ed Pom Dingle. From October the 7th through till the 9th, the 22nd Current Controversies in Anesthesia and Perioperative Medicine and SIAA Autumn Congress will be live from Dingle Island, where it will be streamed around the world right to your home. EdPom Dingle has a certain flavour about it. It's one of the conferences you'll have frequently heard guests and contributors on Top Med Talk refer to in hallowed terms. This is an incredible opportunity for you to be able to go there and enjoy every aspect of EdPom Dingle that makes it so special. We've got the socialising covered, we've got all of the latest and greatest information, and we've got all of the fun you expect from an EdPom conference. Check out edpom.org, and I'll see you there.